So with respect to the therapeutics, we've talked a lot about, hey, even if you have the optimized regimen for the patient that goes beyond even the meds to diabetes to behavioral health and cardiovascular disease and so on and so forth, that it can fall apart, and we've talked a lot about that. But what happens when you have a scenario, because patients are dynamic, patients might start to good diet and exercise. They might end up in a different environment where they go one direction or the other. They may be in an environment where they were started on an SSRI and it hasn't been titrated. What about the circumstance where we generally do have a patient that's able to execute the care plan as formed, and they come back to your exam room and their hemoglobin A1C is 11.5. What do you do next?
So again, if that was the scenario, I'd obviously go through your checklist of where is that discrepancy coming from. But if it was, the patient was on therapy and adherence is not a factor, because that's the one that usually screams out at me when I see something like that, that a lot of it's other, it could be adverse events, patient factors. And so when you look at an A1C of 11, you're thinking insulin, but maybe it's issues with hypoglycemia. It may be issues with weight gain. Are these, the sulfonylureas or other drugs that are causing weight gain, are those the ones that are being prescribed? Patient figures it out within a month or two. I'm not taking this. I see a lot of those scenarios. And so what I always try to do is kind of optimize that regimen. And I always ask the patient, where is it that you want to be? Because we all know where we want them to be, but where is it that you want to be? And sometimes I'll have patients that will come into my clinic and they'll quiz me. They're like, you know what the average life expectancy of a male here in the US is? And I'll give them a number. They're like, I'm 84 or I'm 76. Everything from this point onwards is a bonus. And that's fair. And so that's why I asked that question, is where do you want to be? Because everyone has different goals. And if that's okay, it's good enough for you because you live by yourself and you have other comorbid conditions. And if you do get a low blood sugar, it's going to be a really bad event. And so,
VA study.
Exactly. And so that's one of the reasons why we have our own guidelines and our goals, because we know our patient population is different, and it's okay to let them be a little bit higher if they have comorbid conditions or limited life expectancy. And so I would say that that's probably
So what's fascinating about what you just said to me then is a patient-centered drug regimen, a patient-centered care plan that may not be focused on patient goals as we think of them as the traditional conventional medical model with clinical biomarkers, but rather setting a chart for what are we trying to accomplish at the end of the day with this patient, and then thinking about the drug regimen as here's an array of patient goals that I have from the last visit. Where are we at? Are these still your goals? And then do we need to tweak the regimen? First, are we following the regimen? But then do we need to tweak the regimen in any way because we're not tracking towards those goals? And don't make the assumption that the goals are as you see fit. It's the goals as they see fit.
I mean, it has to be that. If you think about it, we have more drug classes in diabetes than we ever had. And they're all better than the prior ones with less, hypoglycemia, less weight gain. But from a population health standpoint, we've not moved the needle. So obviously, it's not, we don't need more. There's something else. And, I think it's worth a try because the other stuff has not worked up until now,
So Stephen, you've got a list of patient goals. Patient was in 3 months ago. They did a repeat lab. They walk in. Hemoglobin A1C is not where it's at. Maybe they're not happy with some of their other patient goals. You feel like you've done some investigation and they've generally followed pretty well the care plan that you set up in the drug regimen. What do you do next? It's almost like the quarterback checking down. Primary's not working. What's secondary? What's tertiary? What does that process look like?
Well, I mean, we're certainly going, as internists, we're going to leap to medication intensification or optimization. That's just that's how we roll. So we're certainly going to do that. We're certainly going to talk about nutrition. In the clinical setting where I am, we're at FQHC, so not dissimilar to the VA, we have a bit more expansive set of services. So we have a PharmD, who is our primary coach, Dr. Morales. So we're certainly going to invoke her help and support. and that kind of nutritionally based care. So those are the two things in all probability. If we were super assiduous, we might do a home visit and really understand what the home environment looks like, because that can be a very, very illuminating, and some of our residents do that more in family medicine. I'll give you a shout out. So that would be another part of the rubric in an idealized state. But the two things we would look at really are medication intensification or optimization, and then diet.
Well, I'm just happy that we've reached a peace accord between internists and family medicine. The recognition.
I work mostly with family doctors. That's my work is they're in the driver's seat in patient-centered medical home.